Hi friends, let's discuss a very important topic, head injury. The key words used in this session are Glasgow, Coma score, battle sign, raccoon or panda eyes, Lucid interval and Hutchinsonian pupil. So let's discuss this topic under the following headings: Introduction to head injury, mechanisms of head injury, approach to a patient with head injury, complications of head injury, extradural hematoma, subdural hematoma, as well as subarachnoid hemorrhage. So first of all, an introduction. How or what are the effects of head injury? First of all, when you draw a head, you must know that there is a skull underneath this head, right? There is a skin which is called the scalp. Then you have a skull underneath, and underneath that you have various layers of meninges, that is the dura mater, the arachnoid mater, and the pia mater, which is in continuity with the brain. Okay, so injury can occur at any level. For example, there can be scalp injuries like incised looking wounds, lacerations of the scalp, multiple scalp injuries, as well as avulsion of the scalp. Okay, underneath that you have the skull. Skull fractures can also occur as in association with head injury. Also, you can have intracranial hematomas. Intracranial hematomas are any hematomas underneath the skull. Cranium is the skull, so underneath that is the intracranial hematomas. Now, depending on how visible or how approachable each injury is, you can have open injuries like whatever is inside will be seen outside. Okay, so this can cause CSF leak. Now, CSF is a fluid which is flowing in the subarachnoid space, and this fluid can leak out. Okay, so there can be a CSF leak if it's an open injury. Otherwise, you can have closed injuries. Closed injuries means maybe the scalp is not injured, but underneath the structures everything is injured. So you have open closed injuries. Then depending on the layers, you have scalp, skull, as well as intracranial injuries. What about the mechanisms of head injury? How can the brain or the skull, how can an injury or a trauma affect the intracranial structures inside the skull? Okay, one is when there is a distortion of the brain. That is, if this is the brain, you have a skull. Suppose you're shaking this head, okay, here and there, what will happen? The scalp and the skull may remain as it is, but when the brain shakes, what will happen? There are small vessels as well as nerves within the brain. All these structures are very delicate structures which can get injured. So the first mechanism is distortion of the brain, leading to damages in the neurons, blood vessels, as well as supporting tissues. Next is mobility of the brain with respect to skull. The skull is moving, but the brain is moving even more because it is a lightweight structure. So what happens? The brain will hit on the surface of the skull. Okay, now since the skull is a very rigid structure, that itself can cause brain injury, leading to cerebral damage as well as dural bleed. Next is the configuration of the interior of the skull. Have you seen the interior of the skull? If you look at the lateral view, you'll find that this is the nose, this is the mouth, this is the neck. Here you have a proper smooth outer surface of the skull, but internally if you see, there are so many ridges. Okay, and based upon the deeper ridges, it can be broadly divided into three cranial fossa: the anterior, the middle, and the posterior cranial fossas. So because of these ridges, because of the irregularity of the ridges in the base of the skull, that itself can cause minor trauma when the head is subjected to a major pressure, right? So anterior cranial fossa, falx, tentorium, all these structures are making the interior of the skull very rough, and that itself can injure the brain because the friction between the brain and these structures is not controlled or in an optimum manner when there is a force applied on the head. Next, deceleration and acceleration injuries. What are deceleration and acceleration injuries? If the brain is here or if the head is here and there is a rigid structure over here, suppose the brain moves, falls on this rigid structure, there can be injuries happening inside. That is called deceleration injuries. Suppose this hard structure comes from somewhere and hits on the immobile skull, then that is called acceleration injuries. Okay, so what are deceleration and acceleration injuries? Deceleration injuries means, suppose this is the lateral surface of the lateral view of the skull with the brain inside, and you have a rigid structure over here. Suppose due to some force acting exteriorly, the head hits on this structure which is immobile. The head is mobile but the structure is immobile, then it is deceleration injury. Okay. Suppose this structure comes and hits on the head, injuring the skull or the intracranial contents, it is called the acceleration injuries. So when there are deceleration and acceleration injuries, though the full impact is on the skull, it can transmit its impact intracranially. Okay, cerebral concussion can occur, that is a slight distortion in the intracranial contents leading on to temporary physiological changes like transient ischemic attacks, that is cerebral concussion. Cerebral contusion, what is contusion? It is that bluish discoloration which you see after a major blow, right? So inside the brain also there could be such a bluish discoloration called contusion. It is just bruising of the brain, but there can be cerebral edema associated with that cerebral contusion. Next is cerebral laceration. Cerebral laceration, as the name suggests, is a cut in the brain. Cut in the brain. So those are the various mechanisms in which the brain may be injured. Now, what is the approach to a patient with a brain injury or a head injury? First of all, there are certain primary injuries for the brain. One is neuronal damage. Okay, then you also have shearing lesions. Then you also have lacerations and contusions. I remember it as like this, nesh kola, whatever it means. The secondary injuries are nothing but the concussion injuries, the intracerebral bleeds, as well as seizures and infections like subdural, empyema, meningitis. All these are secondary complications of brain injury or head injury, traumatic brain injury. The first few injuries are just minor, and they may be the primary injuries, but the second one, which develops as a complication, are the major ones which could be life-threatening. Okay, so first of all, you're receiving a patient with head injury. Now you can see that the scalp is injured, so you are suspecting a head injury. What are the things which are important to be asked in your history? First is whether the patient is intoxicated, whether the patient has had alcohol or certain narcotic drugs, etc., which can hinder with the consciousness level of the patient. If so, the Glasgow Coma score or the consciousness level which you're assessing would be actually different from the real one. Okay, so intoxication, mechanism of injury, how did it happen? Was there any history of loss of consciousness, vomiting, seizures? These things are typically asked for all trauma cases in the casualty or the emergency department, and look for any external bleeds. Okay, this could be an indication. This is called battle sign. Battle sign means there is a bleed in the cranial fossa, okay, which has seeped through the superficial layers of the scalp, and it is evident in the mastoid area behind the ear. So that could be an indication of an internal bleed. Also, this is raccoon eyes, raccoon or panda eyes. Okay, because pandas have black colored, periorbital periorbital discoloration, and the rest of the face is white. So similarly, this is a panda eyes in which both the eyes are having a bluish discoloration. That could be an indication that there is a cranial fossa bleed. Also, there can be bleed from the ear, from the nose, from the mouth. All these may be clues that there is an internal bleed. Okay, once the history is over, main point of the history is over, simultaneously, actually not once it's over, simultaneously you have to check the patient's vital signs like pulse, blood pressure, respiratory rate, temperature, and also limb movements. Now you would be thinking that if a patient has a lacerated wound on the scalp, why should we check the limb movements? Well, there is something called Kernohan's notch, which is also a keyword, Kernohan's notch. Now look at this figure. Here you find that there is a bleed at this level, right, on one side of the brain. Okay, now because of the bleed in this level, it is actually pushing the brain to the opposite side. Okay, so this is supposed to be the midline, but now the midline will become like this because the brain is being pushed, and this is supposed to be the outline of the brain, but now what happens? It is being pushed here because of the expanding bleed. Now this notch which develops due to coning means the brain is getting inside a cone, that is into the cone called the spinal canal or the central canal. So that is called coning. Coning develops, and this notch is called Kernohan's notch. Okay, so you have, now what happens is that this part of the brain may be filled with lot of structures, nerves, especially the corticospinal tract, the nerve tracts which begin from the cortex to the spinal cord and thereby giving the innervation to the limbs. Now when they are under stress at this point, what will happen? It can lead to weakness of this part of the limbs. Okay, so it can lead to contralateral hemiparesis. So the limb movements, if decreased, might be a clue that there is a bleed which is being expanding inside the brain. Okay, the next and the most important one is Glasgow Coma score. When you call a neurosurgeon for an opinion, the first thing or maybe the only thing he'll ask is the GCS score or the Glasgow Coma score. This is very important. Okay, what is actually Glasgow Coma score? It is remembered by EMB. Okay, eye movements, motor response as well as verbal response. Out of this, which is the most important? It is the motor response. Now let's see what is EMV. Eye opening. The normal one is the maximum. What is the maximum score of GCS? It is E4, M6, V5. E4, M6 and V5. So the total score maximum is 15 and the least is when there is E1, M1, V1, that is 3. 3 is the least and 15 is the maximum. What is E4? E4 means spontaneous eye opening, okay, without any difficulty. E3 is what? You call the patient by the name and then he'll open the eyes, otherwise his eyes are closed. E2 is what? E2 means you call the patient, there is no response, but if you pinch the patient opens his eyes. That is E2. And E1 is no response, no eye opening. What is M? M means it is normal. M6. M6 is normal. You ask the patient to do something, lift your leg, and the patient lifts his leg. That is obeying command. Okay. Then 5 is what? 5 is localizing pain. He is not able to lift his leg and he'll tell you that I'm not able to lift my leg. Okay, fine. So you do one thing, you touch your left arm and he is able to touch it, or you ask him to point the area where you're having maximum pain, so he is able to localize it, or you pinch him and he is able to localize his hand to the area where you have pinched as a reflex. So that is localizing to pain. Next is M4. M4 means flexion to pain. Flexion to pain. 3 is abnormal flexion. 3 is abnormal flexion. 2 is abnormal extension. Okay, abnormal extension, and one is nil. Okay, no movement at all. So there is something called decerebrate rigidity and decorticate rigidity. Now for a long time I had been having problems in remembering this. So I just realized that if you look at the spelling, if you look at the spelling, if you follow the alphabetic order, you see that CE comes first and CO comes next. So CE is abnormal flexion and CO is abnormal extension. Okay, so decerebrate rigidity is like this. Okay, abnormal flexion, all possible joints are flexed, and and CO or decorticate rigidity is abnormal extension like this. Okay. Now, how to remember this? It is easy if you follow a mnemonic which I follow. It is called always, where there is no Y, so all Y. O is obeying commands, L is localizing pain, then A is abnormal flexion, W is withdrawal to pain, okay, that is flexion to pain, A is abnormal flexion, and obviously E will be abnormal extension. So always is a way in which you can probably remember it. V, what is a V score? V5 means what? Oriented, you are able to talk normally. V4 is what? V4 is a little bit confused. How am I in the hospital? Actually, what happened? Like that. Or if you ask the patient's name, he'll be thinking and he might say some other name, for example, for instance. So that is a confused type of conversation. 3 is inappropriate words. If you ask his name, he'll say or something like son, daughter, like that. You're able to understand the word like son or daughter or wife or husband or something like that. But it is not the answer to your question. It is inappropriate. It is an inappropriate answer to your appropriate question. That is inappropriate. V2 is incomprehensible words, which means you ask the patient his name, he say, you're not even able to understand or pick up an appropriate word, forget appropriate word, a comprehensible word. You're not able to understand each noise which he makes. That is incomprehensible, and V1 is nil. Okay, so that is Glasgow Coma score. The next is assessment of pupils. Okay, now when the brain is affected, you know that there are so many optic nerve, optic tract and oculomotor nerve. All these nerves are very important nerves in the cerebrum. Okay, at the level of the cerebrum. So obviously pupils will be affected when there is a cerebral injury or a bleed inside the cerebrum. So you have to assess the pupil, and the normal pupils are equal and reactive to light, Pearl. Okay, you can try to examine each cranial nerve, look for battle sign, look for panda eyes. Okay, all these things are the little examination things which you have to look first. Then of course you can go in detail for a local examination of the scalp, facial wounds, contusions. You can look for crepitus. If there is any crepitus, probably it's a clue that there is a fracture underneath. Then ABCDE as part of ATLS. Okay, first you have to check the airway. If it is okay, look for the breathing. If it is fine, go for managing the circulation. Then look if there is any inability or disability. Then finally E, expose the whole area, whole body, undress the patient and look for injuries. And simultaneously you will have to give him, especially whilst maintaining a circulation, while putting an IV line, you can take blood for serum electrolytes, blood grouping, etc. And the minimum investigation you need to do for a suspected head injury is X-ray skull or CT. Okay, most of the things will be evident by a CT. Okay, what is the treatment? Of course, because this is a trauma, ATLS is the primary treatment, A, B, C, D, E. Then I've already told you that there can be secondary injuries like seizures. So you have to anticipate it and give IV anti-epileptics. Also, because of the pain, you can try to give analgesics. Again, do not give any opioid because that can, affect the Glasgow Coma score and you won't be able to properly assess the proper Glasgow Coma score. So maybe paracetamol or something would be enough. Okay, and also diuretics. Diuretics if there is cerebral edema. Now this is a picture of cerebral edema. See, a little bit of injury can lead to a lot of edema around the cerebrum. So sometimes you may have to give diuretics to relieve that cerebral edema. Also, because there is a chance of infection to develop, you may have to give IV antibiotics. And finally, if all these conservative methods are not working and the patient is worsening, then you may have to resort to craniotomy. Okay. So next is about the complications of head injury. What all can head injury cause? Already mentioned, as part of secondary brain injury, you can have seizures because of raised ICP. You can also have infections like meningitis and also subdural ependyma. And also subdural empyema. Okay, which is an infective process going on at the subdural layer. Then, because of the injury at the level of the base of skull, sometimes there can be CSF rhinorrhea as well as, that is, bleeding or CSF leak from the nose as well as ears, that is CSF rhinorrhea or otorrhea. Brainstem injury can occur. Why? Because see, now that the brain is getting shifted to one side, there could be a midline shift, and here is the brainstem, and obviously the brainstem will also get kinked. Okay, so that could be brainstem injury. Then amnesia, hydrocephalus, headache are all tertiary or secondary or tertiary injuries because of the CSF leak, continuous CSF leak, or poor absorption of the CSF because of the hematoma or due to the infective process which is happening. Dural venous sinus injury can occur by a depressed fracture. Now this is a depressed fracture of the skull. Okay, underneath this is the dura mater. Underneath that you have the arachnoid mater, and underneath that you have the pia mater all around the brain. Okay, now also here you have the dural sinuses, that is the veins. Now suppose this depressed segment goes down further, what will happen? All these structures can get injured. So when dural sinuses get injured, there can be a severe hemorrhage. Okay, so those are the complications of head injury. Now coming to each intracranial bleed separately. Okay, first of all, extradural hemorrhage. Now as you know, see, you have the skull, you have the skin or the scalp. Underneath that you have the dura mater, which is part of meninges. Underneath that you have the arachnoid mater, which is the second layer of the meninges. Then underneath that you have the pia mater, which is in close proximity with the brain. Okay, so you can't have a cavity in between brain and pia mater, but you can definitely have a cavity or a potential space in between the other layers. So when a hematoma develops, either the hematoma can develop here. Okay, so this is the dura mater and the hematoma is exterior to it, so it is called extradural hematoma or EDH. Okay, now this dural matter is actually a membrane like thing, so it can yield. Okay, so what happens? This will yield like this. Along the hematoma it will yield. Okay, so it will have a structure like this, a spindle shaped structure or a biconvex structure. Okay, for me it looks like idli, cross section of an idli. The idli, the snack which you eat, the South Indian snack which you eat, if you take a cross section or a bite of the idli and look at it, it will be like this, spindle shaped. So it's easy to remember, idli, ETH, idli, EDH. Okay, so that is EDH. The next one is when the hematoma develops over here. Okay, underneath the dura. So it is subdural hemorrhage. Okay, subdural hemorrhage. Okay. Now the problem with subdural hemorrhage is that this underneath that is the arachnoid matter, right? Arachnoid matter won't yield much. So what happens? The blood will actually form or the hematoma will be in this shape, which is like a half moon, semi-lunar or concavo-convex. See, semi-lunar or concavo-convex. So S is for SDH and S is for semi-lunar. Okay. Now, the next potential space where the hematoma can develop is underneath the dura. Okay. Now, what is this green structure? I mean, underneath the green layer, which is the arachnoid. So, it is called subarachnoid hemorrhage, and it can seep all throughout the gyri and the sulci of the brain. Okay, so it doesn't have a patterned accumulation of fluid. Instead, it would be more like an intracerebral bleed. Okay, so this is SAH. Now half of the thing is over. That is, what is extradural hemorrhage? Collection between the dura and the skull. How does it occur? It is mostly by fracture. It is mostly the origin is from the temporoparietal area, maybe in association with a temporoparietal fracture. What are the vessels involved? Now this is an MCQ. What are the possible vessels involved? A vessel which is superficial enough to cause hematoma at this level are the middle meningeal vessels, middle meningeal veins or branches of middle meningeal artery. Okay. Now what happens actually? There is a development of extradural hemorrhage. It progresses, reach this level. Okay, the dura mater, the arachnoid, all will be following it. Further, it will push the brain to one side. So there is a midline shift. Okay, this line, which is supposed to be the midline, will be shifted to one area. Okay, in other words, it will be similar to this. It will be similar to this. This is like a extradural hemorrhage which is pushing the brain to one side. That can cause herniation of brain to the spinal cord or to the spinal canal, forming the Kernohan's notch. Okay, leading on to hemiparesis due to coning. Okay, so the same thing occurs in a extradural hemorrhage. Temporal bone fracture causing vessel injury, causing hematoma, and that actually strips the dura. If this is the dura and this is the skull, this dura is getting separated from the skull. Then what happened? That will raise the intracranial pressure. Coning occurs of the supratentorial content. Midline shift of the midbrain occurs. Injury to the corticospinal tract, hemiparesis. Earlier described already as Kernohan's notch effect. What is lucid interval? Lucid interval means, first of all, the patient, when he develops extradural hemorrhage, there would be only a transient ischemic attack, a transient loss of consciousness. But after some time, what happens? After some time, all these things will finally lead on to coning. That will take about 6 to 12 hours. So initially he might have lost consciousness, but after that he is fine. Once coning occurs, his general condition will deteriorate and it will lead on to a second loss of consciousness. So that interval in between two loss of consciousness is actually called lucid interval, so typical of extradural hematoma. Then Hutchinsonian pupil, because of the irritation of the optic nerve, optic tract, and all the nerves, the 3, 4, 6 cranial nerves which are controlling the eye movements, especially the oculomotor nerve, which is having a great control over the pupils. Because of the irritation and tension over these nerves, it can cause initial constriction, later dilatation. That is called Hutchinsonian pupil. Other than that, there could be Cushing's triad, because as part of raised ICP. Okay, first of all, there would be neck stiffness. Other than that, patient will be having bradycardia, hypertension, as well as irregular respiration. So pulse, BP and respiration is important to be monitored. That is Cushing's triad. Now, what is the investigation you could do? There could be so many reasons why patient is having LOC, vomiting, seizure, hemiparesis, and neck stiffness and bradycardia, hypertension as well as irregular breathing. To find or to come to a proper diagnosis, you need a CT, and CT will show a idli shaped or biconvex lesion. Okay, this is a typical EDH lesion. And how do you treat it? Small EDH may be managed conservatively. You can give anti-epileptics, you can give antibiotics, analgesics, and see whether the EDH is settling down itself. But if it is a expanding EDH, you may have to emergency do a craniotomy. Craniotomy means what? You're opening up the cranium, and what do you do? Once you open the cranium, that is the skull, you will find the EDH, and it is blackcurrant jelly. It is more like a blackcurrant jelly like hematoma. It is evacuated. If there is a dural tear, hitch stitches are made, and then the skull is repositioned and the sutures are made, are put in order to bring back the patient to normalcy. Now, what are the complications which can develop due to EDH? Post-traumatically also there can be epilepsy, because it takes some time for the coning to come back into the normal state. Meningitis can occur because of infection, either due to the trauma or due to surgery, and amnesia also, depending on the place at which the hematoma develops. Now coming to subdural hematoma. Again, there are two types, acute as well as chronic. Okay, acute SDH is typical of trauma, and the loss of consciousness is immediate and progressive. What is SDH? Subdural, collection of blood between the brain and the dura, underneath the dura but above the brain and dura. Vessels injured are the cortical veins, again an MCQ. Okay, now what exactly happens? Of course, the vessels are injured, or there is a cortical laceration, and it can go on for a diffuse hematoma. See, this much is the hematoma, and it is semi-lunar in shape, typical of SDH. Coop, counter coop injuries might be. What is coop, counter coop? Sometimes, the injury might be over here, or the impact might be over here. The brain in the skull will move and hit on the opposite side of the skull. That will cause injury over here, because the small blood vessels are broken, and that can lead to subdural hematoma. So impact was on the right, but the injury might be on the left because of the counter coop effect. So sometimes as part of counter coop effect also SDH may develop, and this can cause severe primary brain damage because it is in close contact. It is underneath the dura. Of course, it is above the arachnoid, but still it is in close contact with the brain, so it can lead on to severe primary damage. What are the clinical features? Clinical features are almost same for all hematomas. LOC, vomiting, seizures, focal neurological deficits, raised ICP, Cushing's triad, as well as hemiparesis as part of Kernohan's notch effect. What is the investigation? Once again, CT, where you see a concavo-convex or a semi-lunar lesion. S for SDH, S for semi-lunar. What is the treatment? Same treatment, antibiotics and anticonvulsants. Again, finally, you may have to decompress the SDH by a craniotomy. Over here, once you open the cranium, you might find an intact dura. You have to open up the dura if it is not torn. Then evacuate the subdural hematoma. You can repair the dural tear and then close the cranium. That was about acute SDH. Now, what is chronic SDH? Chronic SDH is typically seen in elderly patients. Now, there could be just rupture of a few veins between the dura and the brain as part of a minor trauma. So, in an elderly atrophied brain, sometimes a minor trauma can cause certain shearing forces which can injure the veins, and these venous blood will collect over a period of time in the subdural space for about 2 to 6 weeks. For example, over here there was a minor trauma in the form of a simple fracture, undisplaced fractures actually, but the small veins, because the patient is elderly and the brain is atrophied, the veins or the capillaries would also be very weak. So the cortical veins may start bleeding slowly, and it pools up by 2 to 6 weeks. it would be a huge lesion. Okay. Now, the speciality of this lesion, unlike other SDH or other hematoma, is that there could be solid as well as fluid components. Okay. And the solid or the cellular component is usually absorbed. Okay. And 50% of the chronic SDH are bilateral. Again, the clinical features are almost similar, like there could be LOC, there could be seizures, there could be raised ICP features, focal neurological deficits, pupillary changes, etc. But over 2 to 6 weeks, the patient is worsening. Initially, there could be only a confusion or disorientation which lead on to frank LOC. Investigations, again, CT scan will show a concave or convex lesion. Now, if you look at the CT scan of acute SDH, you will see that this is more hyperdense lesion. Okay, and this is an organized SDH or a chronic SDH, so it is more like a hypodense lesion. Okay, treatment, again you may need to go for a craniotomy and evacuate the clot if needed bilaterally. On top of that, of course, you have to give antibiotics and anticonvulsant for up to 3 years because chronic SDH can recur. Complications are definitely epilepsy, meningitis because of the collection of the fluid inside the brain causing midline shift, corning, neurological deficits, etc. Or sometimes that lesion or this collection itself can get infected leading to subdural empyema. Okay. Next is subarachnoid hemorrhage. Subarachnoid hemorrhage, as the name suggests, is underneath the arachnoid, okay, which is in closest proximity with the brain. So it is almost like an intracranial hemorrhage or intracerebral, almost similar to an intracerebral hemorrhage into the subarachnoid space, usually from the basal cisterns, which are in close proximity with the cerebrum proper. What are the causes of subarachnoid hemorrhage? I remember it by a mnemonic called BABA hit. Okay, B for brain tumors, malignant brain tumors, A for anticoagulant drugs, B for blood dyscrasias, A for AV malformations, H for hypertension, I for intracranial aneurysms, and T for trauma. Out of this, of course, we are discussing trauma and nothing else. But you see, out of this 8 plus 3, 4 plus 3, 7 causes, 6 causes are more or less medical. Okay, especially hypertension leading on to aneurysms. So the emergency is when there is a traumatic SAH. Anyway, clinical features, the patient will complain of a sudden onset of severe headache, almost described as thunderclap headache. It would be the worst headache in his or her life. So that is sudden onset of severe headache along with vomiting, raised ICP, photophobia, focal neurological deficits, all part of any other hematoma or intracranial bleed, eye changes, dysphasia, etc. and LOC, okay, which is common to almost all head injuries, but thunderclap headache is almost typical of subarachnoid hemorrhage. But you can have differential diagnosis. Headache along with LOC, vomiting, could be meningitis, could be coning due to some other cause. So you have to investigate. Now when you investigate for meningitis, you have a tendency to do an LP or a lumbar puncture. Okay. But the problem with doing an LP, if you are suspecting, at least as a differential diagnosis SAH, the problem is that it can worsen the coning. So lumbar puncture, if you're doing, if there is a blood stain, it means that it could be a subarachnoid hemorrhage and that can worsen coning, so you have to immediately stop the lumbar puncture. Otherwise, if you're doing for meningitis, you can take the CSF fluid and give it for testing. Also, you can take a CT and verify that it is a subarachnoid bleed. So here you see that there is a diffuse bleed here and there, all because of subarachnoid hemorrhage, which can actually seep through the sulci gyri of the brain. Also, you may need to do a carotid or vertebral angiogram. Why? To look for aneurysms. Now, where can you find aneurysm? This is the circle of Willis. Okay, this is the anterior cerebral artery, the middle cerebral artery, and as well as the posterior cerebral artery. The commonest aneurysms are in the posterior communicating artery. Other than that, you can have basilar aneurysms, you can have anterior cerebral or anterior communicating artery aneurysms too. Now, all these branches are actually from a common artery which is called internal carotid artery. Okay, internal carotid artery is a branch of the common carotid artery. Okay, so once you do craniotomy for SAH, what are you going to do? You can do it for aneurysm. In aneurysm, what do? You're trying to clip or wrap or coil aneurysm. That is, you're trying to put a clip on top of this, on top of this, on top of this, like a knot, or you can wrap it or put a coil inside so that it does not break. Okay. Other than that, what can you do? You may have to ligate the common carotid artery. Finally, if you can't do anything, there are multiple aneurysms to be ligated and the bleeding is not settling. Finally, what you have to do, what you may finally do is a ligation of the common carotid artery. Now, when you do a ligation of common carotid artery, what happens to this half of the brain? It will go for ischemia. Okay, and that can lead to hemiplegia. Then, if it is an AVM which is causing the subarachnoid hemorrhage, it can be excised, or you can do therapeutic embolization as and when required. Okay. Now, this is a picture of craniotomy. See, the skull is removed. This is the dural layer. This is the dura. This is the skull. This is the skull. This is the dural layer, and this is the brain underneath. Okay, a picture from craniotomy. If the hematoma is small and does not need craniotomy, a part of the skull need not be removed. Instead, just holes can be applied to evacuate the hematoma. It is called a burr hole surgery. Okay, and where do you put a burr hole for EDH? It is at a typical point. See, this is a point which is 3 centimeter away from the lateral orbital margin. Okay, that is posterior, and 6 centimeter above, 6 centimeter above over here. That is the typical point where the middle meningeal artery bleeds to form EDH. So the questions asked in this, frequently asked in this session are about Glasgow Coma score, extradural hemorrhage as well as acute SDH. MCQ number 1, extradural hemorrhage is caused due to injury to anything related to middle meningeal. Middle meningeal is over here, so this is the answer. Okay, the rest of those do not have middle meningeal. These two are SAH, this is SDH. MCQ number 2, concavo-convex lesions. Concavo-convex lesions is typically semi-lunar, so S for SDH. Okay. Next, lucid interval is typical of EDH. So with that, we have come to the end of this session. Until we meet next time with another topic. Bye-bye.
Docemy.